I know Shirley is in the hall, so I was just gonna wait a few more seconds. I'd be like yelling into it. Righty. We'll go ahead and call this meeting to order if we stand for the Pledge of Allegiance.
Allegiance to the flag of the United States of America, to the republic for which it stands, one nation under God, indivisible, liberty and justice for all.
Yeah.
I forgot to do my roll call sheet today, but you're all here, so you made it easy on me.
Okay, so next up, approval of minutes. I wasn't here for that meeting. Is there a motion to approve?
I'd move to approve.
For a second,
Second.
all in favor?
Aye.
Aye.
It also looks really productive, so thank you guys. I could not be here. I was at camp with my almost teenage daughter, which was also fun and exciting, but okay. See, we have recognition of visitors. So there's people on the line. Is there like a way for them to like sign in to speak or like say they want to? Okay.
Yeah, we also have a little hand raise emoji, and
Oh,
then
okay.
I'll alert you. Excuse me.
Awesome. And then other visitors in the audience.
Yeah, my name is James Page. I'm here from Albany CTC.
Did you used to work for Samaritan Stars? Okay,
Yeah,
I was
a
like,
long
we've
time
worked
ago.
together before.
Used to sit here for a while.
Yeah, I was here for a while.
I knew I recognized her.
I'm gonna say this is who helped to get the Sharps container that I'm
There
always
you
posting
go.
and bragging about
That's
that we
right.
love so much in this community. So I thought I recognized that face. Any updates or are you just here listening?
He's
No.
actually on the agenda.
Yeah.
Oh, okay.
Yeah.
Oh, yeah, perfect. So real quickly, old business health fair update.
As of today, I've got 22 applications back and 23 tables reserved. So that's about on course for what it's about this time of year. There'll probably be about 10 or 15 more probably coming on top of that. And then today I picked up the new banners that I had made up for the health fair so we could be a little bit more out there. And thanks, Cicely, for following up on what you needed to do. Basically pay for them. So, so I appreciate that. But the banners turned out really well. So, that's pretty much it. I mean, and the thing's moving forward. So,
Community partner presentations, and then FAC. Are you providing?
They're scheduled for July the 28th, I think
Oh,
is the
okay.
date, or the 20 something.
I'm sorry. Did I add them too early?
No, it's okay. I'm sorry.
That's fine. Then we'll
Yeah,
we'll
it's the
push it to the next
fourth
one.
week in
Got it.
I just
July.
didn't want them to be online and me miss it. So okay. So all right, James Page from Albany Comprehensive Treatment Center.
You guys have okay, perfect. Not needed. No big deal. But the purpose of me being here is, so we've been operating an opioid treatment program in Albany since 2021. So November of 2021, we opened. We're the only opioid treatment program of our specification, I guess, between Salem and Eugene. So there was about 115 patients from this area, from Lynn County, effectively, who were receiving services up in Salem prior to us opening in Albany, who have now since moved there, and our census has grown to about 350 right now. So the reason that I'm here though is because one of my goals has been to get more services out here. We've had about 50 patients to date, either with us at one time or currently on our census from this specific zip code. But it's still about a 90-minute round trip, right, to Albany. And especially if they're relying on medical transport, we have ongoing issues with that whole process because they often want patients in and out of our building in 2 minutes or, 10 minutes, and sometimes it's just not possible. So anyhow, there's a lot of barriers for patients who live in this area and then surrounding as well. So I'm sure there's a lot who haven't ever tried to venture out to us. So with that gap in services, I've been working with my regional director and our regional vice president on getting services out here. And what I've landed on, which has been approved, I don't have the RV yet, but the reason for my being here is that I'm trying to get a mobile unit here 5 days a week. So it will come from, sorry, my bad. So it would come from Albany, 5 days a week. Out here, we would need to lease space in a parking lot, and be there for probably 3 or 4 hours in the morning. So usually our hours are, 5:30 to 9:30, 5:30 to 10:30, something around there. I mean, we don't have a concrete date or time or anything yet, really, when it comes to all of this process. But I wanted to get out here and sort of let you folks know what I was hoping to do and what our plans are, and I'll get ideas or feedback from you all as I was a part of this committee for quite a while. So that's the plan. Any questions or anything, I guess?
So-
Are you talking OHP? I'm sorry. You talking OHP folks mostly or totally or?
It's about 85% of
Yeah.
our census is OHP. There's a lot of Medicare folks out here too, so that
Yeah,
would
that-
be part of the population. We also are part of the Behavioral Health Resource Network now, so
Oh,
in
really?
July, we'll get more funding for folks who don't have insurance at all or are underinsured. With the Medicare folks, that's oftentimes what we're seeing is they have an out-of-pocket expense that they're unable to meet really. So we're able to use the Measure 110 funding for that as well. So that would be a part of our licensure, because we would be the way a mobile unit works is it's effectively off of our DEA and licensure in Albany. So it's just an extension of the Albany location effectively. It wouldn't be something that we would move around through the community. It would just be at one specific location and stationary there for the time that it's scheduled to be there. And then it would travel back, and, we would dump the gray water and house it at a RV location overnight, and then, do the same thing over again the next day. And that would just be a Monday through Friday operation. Patients would still be admitted and receive counseling services primarily through the Albany location, but as the census grew on the mobile unit, we would look to have a counselor on board there as well. But initially it would be a nurse and the driver. So that would be, I have a picture of what it would look like. It's effectively a small RV that they equip as a medical unit. So it would have all of the same features that our dispensing station does in Albany, except just mobile.
Is that Suboxone and methadone?
It is,
Okay.
yep. Yep, so buprenorphine products and methadone. The majority of folks come to us because we offer methadone, and that's the gap that existed really in the community at the point that we came on board in 2021. And the demand, for treatment, for services has far exceeded what I could have projected, which I anticipate would be similar out here as well, because as you're probably all aware, Dr. Kelly is not, prescribing anymore. And she had about 115 patients on her panel, is what I was told from the county, that I don't know where they ended up going, because they didn't all come to us in Albany. And so there's a lot of folks out here that I assume are just not receiving services, or not aware that services are existing in Albany. At least that's my perception.
So I can speak to that. We do have a new provider that started with us December, January, who did take on a lot of those patients, but
Okay.
I think there was a gap in services when Dr. Kelly left, and so there was a lot that were lost to follow up as well. And so we don't know if they landed at Samaritan being treated by their providers, or I know some of them had mentioned that they were going to act in Albany, and so there's some that we just were never able to get back in touch with and get them restarted when our new provider started. So there is people in the community that aren't maybe aware of these services that need to get back in treatment.
Yeah, and the overdose numbers and the numbers that we're getting from Samaritan, I don't know what substances they're not providing substance level details, so I don't know, but they're still pretty consistent with what they were prior to us opening. And they're not our patients. So it's very sort of confusing how those numbers have remained pretty steady when they're not a part of that 350 that we're currently seeing. So yeah.
So the mobile unit to be stationed here
Yep.
in the future. Now, the clients that come to the mobile, are those referrals from the medical facilities in the area, or is this a person who just walks up to the door and knocks and says, "Here I am and I need help"?
We do admissions via walk-in. Everyone would be admitted at the Albany site. So we would provide transportation via Uber Health from wherever they're at to the Albany location, get them through the admission process, which takes about 2.5 hours. And then they wouldn't have to make that commute again because they would just be able to access services at the mobile unit. Unless there was some, reason for them to access services in Albany.
Hmm.
But
Thank
yeah,
you.
Yeah.
So your main ask right now is help finding a parking lot space that you could lease.
That would be fantastic. Yeah. I mean, I don't particularly have an ask, but it was more of just a sort of, this is what I'm planning. This is what's in the works, and get feedback. And then, yeah, if there was any ideas around parking or, disagreements on us being out here, any of those things are welcome, that's why I'm here. So, yeah.
So is that something, Cicely, that if they were to locate here in Sweet Home, they'd get a permit from the city or something to allow that, or?
Yeah, so there would probably be some restrictions based on the property, just with the zoning, but yeah, we'd probably go through the permit process.
Okay.
Do you have any idea time frame how soon you might be ready to have the mobile unit here?
There's multiple factors that are outside of my control on the timeline. The biggest one being the DEA process and getting that license for the mobile unit. And approximately 3 months, probably. The mobile unit itself is actually in Utah right now, so I have to get it from Utah to Oregon and then go from there as far as the rest of the process goes. But three months would probably be a safe timeline, or tentatively at least.
So I guess a follow-up question, if the mobile unit didn't happen, but yet the services still remain the need, would the group be looking at renting a space or teaming up with another facility to have a spot that you could land?
I don't think so, primarily because of the DEA issues. The state is pretty flexible when it comes to methadone specific operations. The DEA is not. So it would have to either be a standalone med unit, which is a brick and mortar that's not equipped at the same level the Albany location is, or a mobile unit. It wouldn't be something where we could just, be,
Okay.
in a partnership.
Yeah.
Yeah.
I've had folks who are doing the methadone program. They're transported by Ride Line once a day, 7 days a week to programs like this. At least that's what I'm told happens. Will this unit be up here daily for the folks who are have a daily cycle, or is that?
It would be fine, right? So one of the reasons that we closed on Saturdays was because of Sweet Home. So the way Ride Line would treat Sweet Home folks specifically, or anyone sort of outside of the immediate area, was they would have them call on Friday to see if they were able to get a ride on Saturday. So it was always this lottery whether they could actually get transportation on Saturdays. So that was one of the main motivators to close on Saturdays, but we were already closed on Sundays. So now we're closed on Saturday and Sunday. The mobile unit would follow that same Monday through Friday
So it
schedule,
would be up here daily
5 days
for
a
that.
week.
Okay.
Yeah.
Because that's when you think about that, and it's mind-boggling. It was mind-boggling to me that folks are traveling to Albany. We're paying for transportation there every day of the week, and each individual person. I don't even know what that cost is, so it's kind of interesting.
Yeah.
An interesting thing to think about.
Yeah, we have a lot more flexibility now with take-home justifications through SAMHSA that allow us to do a lot more than what we could do 2 years ago. And so we do exercise those flexibilities for our folks in Sweet Home and on the coast. But it's really difficult. The induction phase of methadone is a really challenging one for folks who have been using fentanyl. So it takes 10 to 15 to 20 days to get someone on a therapeutically valid or what's the right word, Wanda? Therapeutically useful dose. It escapes me right now, but so that period of 15 days, if they need to dose in the clinic really every day or every other day in order to increase their dose, because we have specific guidelines we can follow as far as the dose increases go. And so if they have to make it there for 15 days straight, or, minus weekends, obviously, that becomes a real difficult proposition. And then if they're not able to make it, they're not able to experience any benefit from being in treatment with us. And then there's no point in coming back, on Monday or Friday or whatever it is after they've missed that many days. So it's, that's the challenging part, is that initial induction phase and getting them to a dose that's therapeutic.
Can that particular form of treatment, when is it effective? How long do they have to continue to be on this particular program and until they're free?
It's all patient driven. So there's no specific timelines. I can say that the average length of stay that we have in treatment is about 160 days.
Mhm.
So the average patient who starts treatment with us stays in treatment with us for 160 days. And that's absent any other timeline. So there's no like funky work on the statistics there. It's just statistically each patient who admits with us will be there for 160 days
So they
on average.
could be a relapse, or it could be they've just gone without and they're switching off. I mean,
Yeah,
do they
it could
typically-
be that they stay with us for 6 months. It could be they stay with us for a year. It could be they stay with us indefinitely. There's no hard in and out as far as treatment goes. If patients want to titrate off of methadone, it's completely self-driven.
Do you
So,
see that?
Yeah, all the time. Yeah, we have people complete treatment all the time. Yeah, it's a regular occurrence. We have more people right now. So some of the statistics that you might not hear about methadone, we have more people right now not using illicit substances than we do using illicit substances, whether that be fentanyl, meth, or any of the other illicit drugs out there that people are using nowadays. So of that 350, we have about 40% who are getting 13 to 27 take homes, which means they're completely abstinent of all, illicit substances. And then our folks who are getting 6 take homes, if they're not coming from geographically, if they're not coming from a rural area effectively, all of them are not using any opioids anymore or opiates. And so they might still be using stimulants, but we can allow under the safety profiles more take homes in those scenarios as well. So the majority of the folks that we have in treatment are not using opioids or opiates anymore. And then we're working on, the rest of the stuff with them as well.
When you say take homes, is that essentially a prescription? They take home
it's
medication.
Technically not a prescription, but they're
Mhm.
dispensed 27 doses at the time they pick up. They get 1 dose in the clinic and then 27. So they come back once a month.
That's a supply for them at home then,
Yep.
as opposed
Yep.
to,
Yep.
okay.
Yep. Individually bottled in a lockbox.
I was assuming it was, but I
Yep.
want to make sure.
No, I appreciate the questions. Yeah. Any questions that you might have, because I know methadone is obviously a new thing for Lynn County in this area still, even though we've been there for a couple of years. But oftentimes the only representatives we have is people who don't do very well in treatment. And so it's really important for me to tell you that we have a lot of people doing really well in treatment. You just don't see them, and you don't know that they're on methadone because they're doing really well. So it's an unfortunate side effect of treatment, methadone treatment specifically, that our sort of poster childs are often those who make the most noise, and those making the most noise are not doing the best usually.
So are you more of a harm reduction based model or an abstinence based model?
We are completely harm reduction based. Yeah. Yeah, we don't discharge people from treatment due to continued use unless by clinical/medical judgment, it's determined that they're doing worse in treatment than they were before they started with us, which has happened. But it's still a very difficult philosophical justification to make, or clinical justification to make, to send someone out when the likelihood of them overdosing is exponentially less if they continue to take methadone, even if they are using illicit opiates. So of the 350 patients, of the, 900 patients that we've admitted and have left treatment or whatever it is at this point, we've only had one overdose death that I'm aware of, and it was a patient who went to jail, was in jail for 60 days, got out, didn't come back to treatment, and overdosed and died as a result. So she wasn't currently on our census at that time that she did pass away, but that's the only death that I'm aware of all the patients that we served to this point. So there's not a better, thing that I can tell you about our treatment other than that, because we serve a lot of people. And a lot of people who are still struggling, I mean, for that matter,
The transportation that you mentioned earlier, is that just for Medicaid patients, or could Medicare patients access that as well? And is there a cost to the patient?
The initial appointment, we cover the cost of. So the Uber Health ride that I mentioned, to and from their initial appointment, we cover, and it's not billed at all. The ride line is a Medicaid service. Yeah.
Yeah, I knew about that, but a lot of our patients have a hard time because obviously Medicare does not pay for Rideline if you have certain Medicares. And so I just wanted to, I didn't know if that initial visit they would receive some sort of bill for going
Nope.
to meet with you. And then do you have ongoing support like group classes or behavioral health? Okay.
Yeah, so we're an outpatient level facility, which effectively means that the maximum assignment of clinical services that we assign to someone is 9 hours a month. So that's comprised of 8 hours of group and 1 hour of individual counseling, and then patients step down from there. Patients can always access more groups and individual sessions, and we have a lot of folks who do, but that's the maximum that we can assign them with our licensure being outpatient specifically. So 1.7 is what we are.
And you currently have 350 patients on your
Yep.
roster. Is
Yep.
there a cap under your waiver of how many patients
No.
you, okay.
No, it's not like the Suboxone or Bupe stuff. Yeah, no X waiver stuff. We have 6 full-time counselors now. So 6 full-time counselors. I'm the acting clinical supervisor right now, so that's fun. Yeah. We're actually in the middle of the state audit right now, so they just left right before I headed this way. So,
Thank goodness.
yeah. Yeah, and we're, as far as what we do, we're the most, I got to figure out a better way to say it, but we're the highest regulation, we're the most highly regulated treatment modality there is, and methadone is, in my opinion, the most highly regulated substance there is. So we get biannual DEA audits. So they come in, they say, give us all of this, and we give them all of that, and they say, give us more of this, and you know how that goes, or you can imagine. Those are not the most pleasant. But so the DEA comes in every other year or every 2 years, and then the state comes in every 2 years, and then we have CARF coming in every 3 years. So we just had our CARF audit in May, and the state, and then the DEA will be next. And everything we do is extremely regulated. It's much different than Suboxone or Subutex and all of that stuff, and outpatient residential.
Is there any insurances that you do not bill?
There is, but because in July we'll have that Measure 110 funding, it should be a non-factor unless we fill up the amount of slots that we have to pay under that. And it's sort of an odd list of insurances that just happens to be we're not contracted with. Yeah, so I don't have a list, but there's a few.
I have one.
Yeah.
I sat on the board of FAC. Do you know what FAC is? The Family Assistance. It's a homeless site here in town.
Okay, yeah, no, I wasn't familiar with it.
Okay. I'm wondering if we have clients there, how would we connect them with you?
So we, as sort of obnoxious as it can be at times, we do have a 24/7 call center. So someone can call at 3 a.m. and get scheduled for admission the next day. If when they call in at 3 a.m. they say, "Hey, I need a ride," then when my secretary or I don't have a secretary. I need more sleep.
It'll happen, yeah.
When my front office gets there, she would call them and get that Uber Health ride scheduled, or if she's out, I would do that. But we do that 24/7, 365. They can get scheduled. We do admissions 5 days a week.
Okay.
If someone walks in, as long as they walk in before 9:30, Monday through Friday, we'll get them in same day. We don't reschedule folks. We don't, that's one thing we prioritize is getting people through the door, however we can. So, yeah.
Do
So
you have a card that you could share?
I do. Yeah.
I
have
would
a
love to
card.
have one to pass on to our
Yeah.
executive
Yeah.
director.
I wish I would have brought, and I can always connect with you all and bring out pamphlets and IPs and all that good stuff too, if it's helpful.
And I think a phone number would be the most helpful.
Okay.
Is there a referral platform you guys are using like Unitas, or is it just having the patient call the call center?
They can call the call center or call the clinic directly. It just matters what option you hit. If you call before 2 p.m., it's easy to get a hold of someone at the clinic. After 2, it's only myself there, so it's hit or miss. But yeah, either way, through the call center or calling the clinic directly. I think through the website, there's also, you can do web form if you wanted to go that route, not if you didn't have phone services or a working, volume button or whatever it is.
I don't know if it needs to be said, but for folks who haven't got a past in all of this whole thing is remarkable. I sit as a liaison to the alcohol and drug group for the county, and this discussion would drive them nuts. And even to this day, although it's probably only about 2 years ago, the discussion came up with medically assisted treatment, and about half the room was pulling their hair out, not having anything to do with this. This is really nice to see, and nice to see someone of your background and quality kind of heading it up.
Thank you.
It's not really hit or miss. This is really a serious discussion. Not everyone believes in this.
Yeah.
But there's 350 people is a bunch.
Yeah, and we've treated a lot of women who either came to us pregnant or got pregnant while in treatment. A lot of them have been, or all of them, I can say, who have stuck with us have been extremely successful. We've got a lot into residential at Stars or at Milestones, and they deliver their babies and they're healthy. And some of those women have titrated out of treatment completely. We've seen just a lot of tremendous outcomes that otherwise, those women were probably not going to succeed on buprenorphine products, unfortunately, or however. So yeah, it's been an uphill battle because it's a method. People hear methadone and it creates uncomfortable feelings for folks or memories of a bad outcome and those types of things. And so it's been a lot of discussions like this and a lot of referrals and a lot of open-mindedness and things like that. But I know there was a lot of pushback from putting it in Albany and people didn't want it there, and there's probably still people who don't. But when you're dealing with over 100,000 overdose deaths a year
Yeah.
as a result of opioids, and nothing we're doing is working, right? The sort of counterfactual is we had buprenorphine that was, on every street corner throughout that process, and those numbers just kept going up and up and up. So if it was about simply more buprenorphine, that wasn't going to do it. Methadone is the far superior treatment modality for folks with opioid use disorder, severe or moderate or severe. Not to sound like an infomercial, but it just is. And unfortunately, folks who are using fentanyl, that medication is their best option, really, most of the time, right? There's no absolutes at all, but most of the time it is. So yeah, I think it's prevented a lot of overdose deaths in the area, and yeah, the counselors and everything doing a lot of good work over there. So yeah.
Anyone else have any questions? I will just say, as someone else who has worked in the community in a MAP program, I think this is a great service to have. And if there's anything we can do as a committee to help with the process, help find something, help talk to council, maybe if there's permits or things needed. I don't know what that process looks like because we're new to some of this. Like I would be willing to write a letter of support because I think it's a great service to have out here. I've seen the need in the community and in some of the patients that we've served, either past or present. And so huge fan.
Awesome. Thank you. Yeah. And there's no monopoly on treatment with us. So if they're engaged in a higher level of care,
Yeah.
we completely suspend their obligation to do clinical services with us. So there's no double billing issues or group code issues. So, if they're doing intensive outpatient, focus on doing intensive outpatient. You can utilize our medication and then step down to us when you're ready to step down to outpatient. And it's the same thing with residential. And so, we just want to be a part of the team, not the end all be all when it comes to any of this, because our clinical services, albeit great, and we have a lot of phenomenal counselors, are not intensive enough for a lot of folks. And so in those instances, we're, more than happy to be referring them to other services when they're willing, which is the hard part. Yeah.
Just one more question about how it functions. Do you
Yep.
find that you're able to, you're talking about getting them to make the decision to go into treatment, make those decisions. Do you find that it's easier once they've been down this path than compared to when they're actively out in the community using whatever illegal substances they're dealing with?
Yeah, I would say that it increases the likelihood that someone would engage in a higher level of care at some point, primarily because they don't have to, their anxiety and fear around withdrawal and detox and that whole thing is mitigated to some extent. And so those folks feel probably slightly more autonomous than otherwise. But it's not to say it's without fail by any stretch. We have folks in treatment who seemingly want to stay in treatment and want to keep using. We continue to see them, we continue to counsel, we continue to have them go to groups, we continue to fight the good fight. But it's really no different than, someone dealing with diabetes or hypertension and, they're not adhering to their diet. You're going to, take away their insulin. I mean, it's it is what it is.
Thanks for bringing it to the county.
Absolutely.
Yes. thank you.
Appreciate it.
Yeah, I hope we can make it happen, and
Yeah.
and yeah, I think it'd be a great resource for you guys.
Have you met Sean?
Yeah, we met before.
Connection, yeah.
Yeah,
okay.
yeah,
Or
it's been a while.
I thought so.
Yep.
Yeah, if we could get business cards and then just keep in touch with how things are going on
Okay.
the unit, if there's anything. you
Okay.
need.
I did not bring any with me. I apologize. I thought I had them in my bag, but I did not. It was a battery. So, yeah, I can bring some by. Where would be the best place to bring them?
You can bring them to me. We can probably put some out at the PD even, somewhere maybe.
Would they get to you, Larry? If it was-
Yeah.
Yeah, and I can get them straight to FAC too.
Okay.
So
Okay. Sean, can I get I might have your number already, but if I don't, could I get
Has your
it?
number changed?
No.
I might have it. That's 541-409-7343. And anybody else who can hear it, call me too.
7343.
7343. Not a secret. You can hand it out to whoever wants it.
There you go. I just called you, so you got mine now
Awesome.
too. Sweet. Well, I will
Gotcha.
connect with
Great.
you and get some cards, and I'll bring some pamphlets too. They're somewhat helpful at times, so do all that. But I appreciate you allowing me the time, Wanda. Thank you for getting me in touch with Cecily. Sorry. All right. Thank you all.
Thank
All right.
you.
Thank you.
Good seeing you again.
Yeah, great seeing all of you as well.
Welcome back.
Yeah, good to be back.
Yeah.
Any committee business for the good of the order? Anyone online wanted to chime in or say anything? I need to get better at looking at Adam. Okay, perfect. All right, any committee business? Any update?
I had a quick one. This is, I don't know, just my mind going bozo. With all this stuff that, well, it didn't start, but kind of culminated in the whole assassination thing in Minnesota, it occurred to me that maybe as a health committee, someone could help me try to figure out how maybe we could start working on kind of crisis intervention as a kind of a health need in the community. The community itself had a bit of a scare with some recent folks. It did not get as serious as Minneapolis and all, but it just occurred to me that we're just not we're not doing well with crisis intervention. And I know there are people that teach that kind of stuff. So if somebody's got something floating around, if you have an idea or whatever, maybe let me know. I got a hold of the education hub at Samaritan, and I got back, I don't know what to do either. And I'm getting that a lot. I don't get a lot of folks disagreeing that at some point we got to start, particularly I think, teaching our youngsters how to get along with each other when they don't disagree, since the adults aren't doing this very well. So I'm just kind of laying it out there. It might be a good way, because we've talked about what to do as a community kind of educational forum or whatever. It might be a way to get somebody in here and we could set up some workshops or whatever. We don't necessarily have to start on a government level, but it would suit us to do it. Anyway, I just want to lay it out for the rest of the group, folks that you might know. I've spent a little time online. Like I say, there are folks out there that do it, but it's on this broad base. Maybe somebody has some insight.
Can we get that on the agenda for next time? Can you make a note of it in case I forget? Crisis intervention / postvention. I know before I started on the coming to committee meetings, I was a part of the Lebanon Suicide Prevention Task Force before it disbanded. And that was one of the things that we were looking at for the Lebanon area as well as Sweet Home, because we had just a mix of people who worked in both communities. And it was more around like suicide postvention and what crisis would look like from community partners getting involved and like going to the schools. But I can look at some of the resources I might be able to find in just from those discussions and then go from there. Because I know we had like key players in the community that got involved due to the amount of suicides we were experiencing at that time, that were like, hey, if we can help support our community after an incident like this, what can we do? Can we bring food? What do we set up for the families? So I know it was really tailored towards that, but maybe we could look at that model as something for any crisis that happens.
I had thought of the QPR folks.
Yeah.
you know, that,
Well, I know there's been a lot of like accidents in our area, like car accidents and things that can be traumatic to kiddos that have just got out of school and now they're experiencing the loss of a friend and not having that school counselor to go to process those things. And what does it look like for them over the summer when they don't have access to things they normally would have access to at the school? And so I think that would be a good thing to kind of do a deep dive into and put on our radar.
I was thinking more conflict resolution of, you know, between individuals, but we can start a number of places.
Well, I think that's a good point, especially you tie it back to the school district. When we think about what they were faced with, I mean, I have a granddaughter that's 13 and I'm seeing this shift, but so much of it, the controversy is around social media because social media is easy to just throw something on it, but you don't have to back it up with anything. And that communication starts getting fractured in those relationships. So I really see that.
Yeah, well, as the adults, your solution is turn that off. Well, it doesn't fix it. It actually makes it worse because you go to the garage and turn it back on, you know? It's that, you know, how do you deal with this thing that the adults don't get, the kids? And I don't mean to, like I said, I don't mean to zero in on the kids. It's just, it's that old prevention is probably the best way to get this thing going, but that doesn't save the generation that's falling apart.
Yeah.
Anyway, thanks for the forum.
I just had one thing I want to kind of follow up on because of our previous meeting. We had talked about supporting Samaritan, and so I reached out to Marty Cahill through Samaritan. He had left on a family crisis, is why he couldn't make it. So Cicely provided with me with 3 alternate dates. So I reached out to the administration there, and I did that yesterday. So I'm pinning on a call back to make that happen. But Marty did definitely show an interest to come to Sweet Home and, you know, sitting with us and just talking about Samaritan in their direction. So should see that coming up.
Thanks for your information also, Wanda, that you shared. It's good.
And then the only other thing I have is I know that we've talked about the wanting to do the health forum, and Shirley had shared that there's space set aside in the senior center for October. So I think I would like that on the agenda to talk about, because if we're wanting to schedule guest speakers, the earliest we can get stuff, or the earlier we can get invites sent out, and provide information on what we're trying to do, I think the better. So I would like to have a deep dive into that next month. Anything else? Okay. Anything else from online? Making it so easy. Okay. Well, what time is it? 4:43. This meeting is adjourned.